Stem cell therapy is just much more invasive, more expensive, more time consuming, and doesn't really seem to do more than the low white cell autologous conditioned plasma in terms of dealing with like symptoms of mild to moderate arthritis.
Welcome back to the Bendy Bodies podcast. I'm your host, Dr. Linda Bluestein, the Hypermobility MD, a Mayo Clinic trained expert in Ehlers-Danlos syndromes. My guest today is Dr. Jocelyn Wittstein. Dr. Wittstein is an orthopedic surgeon at Duke University School of Medicine, specializing in sports injuries and joint conditions. Her research emphasizes ligament injuries like the ACL, joint instability, and factors affecting musculoskeletal health, including areas relevant to hypermobility such as tissue resilience and hormone influences. I'm really excited to have this conversation today because we know that there are so many people who are dealing with orthopedic injuries, and it is really challenging to sort out when surgery might be indicated and when you should take a more conservative approach. This podcast is for education only and is not a substitute for personalized medical advice. Stay to the end for a hypermobility hack. Here we go. Thank you so much for listening to Bendy Bodies. We really appreciate your support. It really helps the podcast when you like, subscribe, and comment on YouTube and follow, rate, and review on all audio platforms. This helps us reach so many more people and spread the information to everyone. Thank you so much again, and enjoy the rest of the episode. Well, I'm so excited to be here with Dr. Jocelyn Wittstein. Thank you so much for coming to chat with me today on the Bendy Bodies podcast.
Thanks for inviting me.
Yes, of course. So as you know, this podcast is for people who have joint hypermobility, connective tissue disorders, and that often involves joint instability, dislocations, subluxations, all kinds of things like that. And so can you start out by telling us what this means when we talk about joint instability? How should we be defining this?
Well, we actually talk about this a lot in orthopedic surgery. There's a little bit of a difference between instability and laxity or hypermobility. There are patients or people who have hypermobile joints. They have a lot of laxity, but they're able to control the stability, of their joints. Someone who can voluntarily pop their shoulder out or pop it back in because there's so much laxity in their joint, but they're able to live their daily lives without, instability, as opposed to like someone who has so much hypermobility and laxity, but doesn't have that control. And every time they lift their shoulder up, the ball falls out the back of the socket. They're experiencing, instability in the setting of their hypermobility. So there's actually a lot of nuance in between differentiating between instability, laxity and hypermobility, but hopefully that example kind of helps clarify that a little bit. And hypermobility can be like diffuse, can involve all of your joints and ligaments, or it can be some people have just hypermobility and laxity of their shoulders or the patellofemoral joints. It's not always, whole body hypermobility. So that's another nuance to that.
Mm-hmm. Yeah, we talk about that a lot. That's really helpful. And so it sounds like, as you're defining this, the control is a very important feature, how a person is able to control that joint.
Yeah. I mean, a person can experience instability or not in the setting of having hypermobility and laxity of joints. Depends on the person.
And what about the difference between dislocation and subluxation?
So subluxation would be an incomplete translation of the joint. Like your patella, it can slide partly over, but doesn't completely dislocate. It's like a partial dislocation. And dislocation means the entire surface of the joints that are supposed to be articulating are completely, out of place and then back in. So a dislocation is, more severe than a subluxation. And subluxations can be hard to detect because they don't present in the same way as, like a traumatic dislocation, for example. The patellofemoral joint is a great example of that. People will have these subluxations, these partial excessive movements of the patella, whereas a dislocation might be, visibly the patella is completely out of the joint and then goes back in, followed by some swelling, that kind of thing. So it can be a little subjective because obviously we don't see everything that happens to someone over the 24 hours of their day or whatever. So,
And that's what I tell people too, that, because I'm hypermobile, I have hypermobile EDS, and I did not realize that I was subluxing different joints in my body. I never had to go to the ER to get a dislocation reduced or anything like that. So, you just know what your own body feels like, right? You don't know what other people's bodies feel like. So you don't know what is, quote, normal, although maybe some degree of subluxation is something that a lot of people experience. I'm not sure whether they have joint hypermobility or not.
and also, there can be a big difference between people who have a traumatic instability event that don't have underlying hypermobility versus people that have hypermobility. They can have dislocations that are less traumatic because the play in the joint allows that to happen without so much traumatic damage being done with each dislocation. But there's like more micro damage that can happen with that like chronic instability. So there's quite a spectrum of instability. You know, the very traumatic type that doesn't have any underlying hypermobility, and then the very atraumatic type that happens with just activities of daily living in the setting of a lot of hypermobility. And there's definitely people in between that have hypermobility, but then they have a traumatic event and the joint that didn't bother them a lot before now does. And so there's really extremes and everything in between.
And is it true that if you're hypermobile and you have a lot of joint laxity and you have some joint instability, you can experience a dislocation and it can either reduce on its own or you could self reduce it, but you're not having to go to the emergency room? And so I feel like there's a lot of people who think that if it's not having to be reduced in the emergency room, that it's not a dislocation.
Right. So people who have hypermobility are much less likely to need someone else to put their shoulder back into place because it won't often get like locked out of place. It can be out very quickly and very quickly go back in. And again, because think of something that's stiffer and then gets displaced and out of place, you're going to cause some actual like anatomic disruption of fibers or ligaments or stabilizing structures, as opposed to something that has more laxity. It can stretch to be out of place and then recoil and go back in without, because there's more give in the structures don't necessarily fail or detach or become, disconnected, but they have the give or the slack to allow that much motion in the joint. So they also go back in much more easily. So there's, again, quite a spectrum there.
And when you're taking a history, what are the things that make you think this is something I need to worry about?
I mean, people will say this runs in their family, like, oh, everyone in my family has hypermobile joints, or, um, someone who has an instability event with very little trauma, like someone whose patella dislocates just getting out of the car or simply like walking or standing up from a chair, as opposed to someone who, um, was, I don't know, swinging a bat really hard and pivoted with their cleat and it got stuck, or, something where there's more force on the joint where you would think, oh, there was some acute injury or just bad placement of the joint versus a simple activity of like simply standing or walking or getting up from a chair. There's different degrees of trauma causing the instability event. If it's very atraumatic, we start to wonder, is this someone, who has hypermobility? Um, there are certain overlapping conditions we sometimes see, um, you know, POTS or, postural changes in ability to maintain your blood pressure. Or there's a lot of overlap of that with hypermobility. And the thought is that that might be due to just sort of the um, ability of the vessels to, provide tone essentially. Just like perhaps there's more laxity in other, tissues, perhaps in vessels as well. And that may be why there's a big overlap in those conditions. Yeah, so those are some of the things. And of course, whenever I see anyone presenting to me with the complaint of instability in their joints, we do a Baton score, which is, I'm sure you've talked about
Oh,
on
yeah.
your,
Talked about it ad
yeah.
nauseum. Yeah.
Yeah, it's just a way to assess for hypermobility, a quick test of 9 points that can easily be done to see if someone has generalized hypermobility. Um, but again, I'll have patients who don't have a really high Baton score who have clearly atraumatic ligamentous laxity of their shoulders or their knees or something that's not involving every joint. So it's not a perfect scoring system.
Well, also, as you mentioned at the very beginning, they could have localized joint hypermobility. So they might be hypermobile only in their shoulders or,
Correct. Yeah.
right. Yeah. 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 So they might not have generalized. Okay. So, and we're going to get more into some of the like nuance of surgery and things like that. But just for the big picture, what patterns would you see that make you concerned that this person might need surgical intervention?
Oh, people who are sort of failing multiple rounds of high quality physical therapy where they're really engaged in it. Um, uh, when there's joint damage occurring because of the instability events, I think it's always easier to give concrete examples. So I don't mean to give too many examples, but if someone dislocates their patella repeatedly and now they're chipping off some of the cartilage in the back of their kneecap from it dislocating, um, that's not good. We need to make an intervention. Or um, someone can compensate for and be doing okay with hypermobility of their shoulder, even though they have instability events that are like fairly atraumatic. But then there's one that's kind of traumatic, and now they have a labral tear on top of a capacious capsule on their MRI. And it's just kind of like too much for the shoulder to tolerate because now there's, more than one issue contributing to instability. Um, in the shoulder specifically, which is probably the most common joint I end up seeing for hypermobility, there are patients who um, really, sometimes I see people who've been to physical therapy like 4 times for 3 months, or they're like, "I've been in physical therapy for like 5 years." It's like not getting better and their shoulder's just not functional for them. There is, reasonable evidence for doing like arthroscopic capsular plications. Certainly the results can be tempered and sometimes can stretch out over time, but I think just kind of really listening to patients, seeing like what have they done and tried, what was the quality of the physical therapy that they did, what are the things that they're not able to do? Is it like simple functional activities of daily living, or are the goals maybe something I would discourage people with generalized high level hypermobility to avoid, like being a cheerleader tumbling on hard surfaces when you have really loose shoulders that, that's probably just not a good choice. Like there are choices to be made sometimes in the setting of these conditions, which we can't completely fix with surgery many times. That if that makes sense.
And you grew up as a, uh, you were a gymnast, correct?
Yeah, I was a gymnast. Yeah, I have been a very hypermobile person for much of my life. My Baton score has probably diminished over the years, which is that does happen. I tell people this all the time. People who are really hypermobile when they're young kind of can become sort of more normal mobility uh, when they're in midlife when other people might be stiff. So sometimes, not for everyone, but sometimes over time, hypermobility and generalized laxity can resolve a little. I don't not fully resolve, but like can become a little different in midlife than it is when you're young. Because everyone gets a little stiffer as they get older. It's just people who are really hypermobile, they don't get as stiff. So
And let's talk a little bit about joint noises or sensations, because I feel like this is an area that's confusing for a lot of people. So, and there's a difference in my mind, I guess, in terms of if you move a joint and it makes a noise versus people who will crack things on purpose. So when people are either the noises happen spontaneously or with some kind of forced maneuver, are those always subluxations, or can joints make noises without having a subluxation? Is there any way to correlate that?
I mean, joints can click and pop, and even like young children with pristine knees and pristine cartilage can sometimes have crepitus. So, like that clicking and popping, especially behind the patella. So, crepitus, I kind of think, clicking popping can be not what we think it is. Like, there's so much clicking and popping. Shoulders are very clicky poppy joints, patellofemoral joints very clicky poppy. As you bend and straighten your knee, every single person's patella will exit the groove and then enter it, at various degrees of flexion. And so, sometimes people have a little pop with the entry and exit of the patella from its groove, for example. Um, we have layers of tissue that allow, for instance, the rotator cuff to glide underneath the deltoid that can click and pop, and your AC joint can click and pop. So sternoclavicular joints, so many joints have normal clicks and pops. Um, there are clicking and popping sounds or feelings associated with certain subluxations or dislocations or translations of the joint. Like a classic one is like when the shoulder goes out the back, and then as you bring your arm up and over, it sort of slides back in. You'll feel like a little clunk. So there are things like that that are actually signifying like the joint sort of exiting and re-entering the groove. But not always, and it's confusing because sometimes you don't really know what the clicking or popping is coming from. The hip is another example. Some people have like snapping from their IT band or their greater trochanter or their iliopsoas deep in the hip, or it could be maybe you've got some hip dysplasia or labral abnormality. So there's all kinds of things. I think it's hard for people to figure out what's actually clicking and popping.
I remember seeing I was working with a physical therapist for shoulder problems, and then I was talking to her this before I knew that I was hypermobile. Well, I have to back up. I had an elbow that I had a submuscular transposition of an ulnar nerve. And at that time, the orthopedic surgeon measured my elbow hyperextension and said, oh, yeah, it's like 22 degrees hyperextended or something. And this is at the Mayo Clinic back where I trained. And he said, so you're going to lose that hyperextension. But he never told me like what it meant. So I was seeing this physical therapist for now a shoulder problem. And I've been in and out of PT, like you said, for like my whole life.
Yeah.
And yeah, and I said something about my shoulder and clunking, and then it did it during when I was actually there with her, and she had her hand in like the right spot that she could feel it, and it was like clearly that was different than like you said, the like clicking and popping. So are there certain things that people other than saying clunking versus clicking, is there something that they can pay attention to that will help them identify like which noises maybe are more concerning than other noises?
I think it's really hard for non-medical people to I can't tell you how many people come into orthopedic clinics asking about clicking and popping, and most of it's not concerning. I just think it's a really hard thing to translate. I think that most people with hypermobility can sense when their shoulder or hip or knee or whatever is kind of subluxating or slipping out of place. The A sound is probably not what's giving you that clue, though.
That's very helpful. The sound is not the most important part there. And what about patients who feel unstable all the time, but they don't have, these classic, really dramatic dislocations? How do you handle that?
I think life as a person with hypermobility can be very frustrating because I I do see patients going doctor to doctor to doctor, frustrated that there's not necessarily a solution for or a way to get rid of this sensation of generalized instability of joints. And that's because it's like inherent in the structure of your body in many cases. And so there isn't a magic wand. I do tell patients, like, you may not be having frank dislocations, but no one is inside your body. No one can feel what you're feeling. You may feel like subtle extra movements in your joints that we cannot resolve surgically, like, having just this few sense of instability in all of your joints. It probably has to do with your generalized, laxity, the structure of your collagen, things like that. Um, I try to empathize with people and and recognize that there is definitely a higher likelihood of people with hypermobility having more joint pain. I see a lot of joint pain as people get into, even their 30s, 40s, and certainly later on in life, because these micro motions of the joint, even if they're not like full on dislocations or even subluxations, just maybe like this hypermobility is creating probably little, small micro damages or shear forces across cartilage surfaces, menisci, labrum, things like that. And I definitely see people who have chronic joint pain. That's definitely a component of hypermobility. So, I usually tell people like try to make lifestyle choices. Again, don't choose to play contact sports. Finding what feels right for your body. It may be swimming, maybe it's not high impact, maybe it's lower intensity strength training at higher repetitions, not like super high intensity, maybe not Olympic style lifting. I think just finding what you can do to strengthen the muscles around your joints that feel unstable can provide some stability, but we need to find, each individual has to find the way that they can do those things. And um, I I think a person with hypermobility who finds a physical therapist that gets them is really lucky because it's just, I think people with hypermobility are in and out of physical therapy and eventually like learn what to do and what works best for them. But think trying to maintain strength and not like super high intensity ways, and then, choosing activities that are less aggravating because we're not going to change the substance of your collagen we're not going to change the essence of you as a hypermobile person. There's not like a medical treatment for that. And that's frustrating. Um, Probably not the answer you wanted to hear, but
Well, I am going to insert something in there because we're discovering more and more about the immune system and especially mast cells and how mast cells release mediators that can degrade connective tissue. So there are some people, not everyone, but there are some people who might have hypermobile EDS, the phenotype of hypermobile EDS or HSD, but it's actually based in their immune system. So when we work on their immune system, and this has happened with a lot of my patients, where we stabilize their mast cells and they actually get dramatic improvement in their joint instability. So there's no magic bullet. You're right. There's no single magic bullet, but stabilizing people's mast cells in some cases can really make a significant difference.
yeah, I mean, I'm sure that's promising and that's good. I think in the orthopedic office, though, we're certainly that's going to be out of our wheelhouse,
Yeah,
the mast
totally.
cell
Yes.
concept. But I see a lot of young athletes, and the other issue is that also many times certain body characteristics tend to select into certain sports, and I don't think the sport makes I don't think being a gymnast or a dancer makes you hypermobile or a swimmer with amazing shoulder mobility. I don't think that causes the hypermobility, but sometimes, hypermobility is a gift and a curse. And so like some people are able to excel in those sports for certain reasons because they have the hypermobility. They can move their hips or their leg in a way that many people can't or whatever, or have that reach in swimming. But it's really important that those people maintain like strength in the small and large muscles around those joints that then stabilize those joints too, because again, it can be like a gift and a curse if you start having this sense of instability. Um, so I think I'm mostly seeing a lot of times like the younger population trying to like get through their athletic life and then experiencing these subluxations and dislocations.
And there's a big difference to me between somebody who's, functioning well except for their right shoulder versus
Yes.
somebody who has more diffuse joint instability. And it's like, okay, we need to work on this holistically and not, play whack-a-mole. But if it's like otherwise I'm doing pretty well, but I just have this like, one big problem. Yeah.
Yeah. And, there are higher failure rates oftentimes in surgeries in people who have generalized hypermobility. And I think we have to recognize that. And sometimes we need to do things a little differently. Like, for example, someone who tears their ACL but has generalized, like their Baton score is like higher than 5 and they have, more than 10 degrees of extension in their knees. Like, that's someone where we may do our surgery a little differently. Like I might add something called an internal brace, like, something to stiffen the reconstruction, or I might add an extra band on the outside of the knee called a lateral extra articular tenodesis, recognizing that there's a greater likelihood of failure, right? Or something that's going to try to improve the outcome of those people. So we can be a little strategic too, depending on the surgical intervention.
So that's great that you are altering your technique based on the information that you're getting from their Biten score, or if you're suspecting that they have joint hypermobility. That's really important. And I do suggest that people ask that when they're talking to a surgeon, how do you alter your technique? Do you have other questions that you think people should ask surgeons that will help them know if the surgeon is, comfortable and or, has operated on a fair number of people that have joint knowingly? Because we all have, or they all have,
Yeah.
any surgeon will have, but
Yeah. I
yeah.
mean, I think most, maybe I'm wrong. I think most orthopedic surgeons are aware of hypermobility. And I do want to say, like, I think unless you have something that really needs surgery, the reason you might see surgeons not jumping to surgery is because surgeons know that sometimes one surgery can lead to another in people with hypermobility. So I sometimes feel like patients are frustrated, like they've gone to a surgeon, they feel like something is being kept from them, or they're not being like, there's like some gatekeeping of surgery. And it's like, eh, you know, because the surgeries may not work as well, or might lead to another surgery, or it may work for a while and it might stretch out, or like that kind of thing. A lot of times surgeons are trying to spare you a surgery like we want to do surgeries on people when we think we're highly likely to help them and they're going to do well. And, um, that's where it gets into like a shared decision making with the patient. Like, have you had really good PT? Are there lifestyle modifications you can make? Do we want to go down this road of surgery? And there might be a higher likelihood of failure, or it might help for a few years, it might switch out again, that kind of thing. But I do sense that frustration that patients have, like this, like as if someone is maybe not understanding what they're going through and not like giving them the solution. But sometimes there aren't sometimes there aren't great solutions. And sometimes there are with maybe not as good of outcomes as there could otherwise, be. So
I'm actually married to a surgeon. I'm married to a urologist. He's retired now, but so I know, he likes to do surgery, and he would tell me about patients that would be, he wouldn't get some of their name, obviously, but people who would be so upset that he would not do surgery on them. And I think this is a really important point for people to understand that for the most part, you like you said, that's the what you're gonna offer somebody, right? When they come to you, you're an orthopedic surgeon, so you're
we
not
like
gonna
to do
say, "Here, take
surgery.
these." Yeah,
Yeah.
you like to do surgery. You're not gonna say, "Take these 5 different drugs for your mast cells." You're gonna say, "I can either do surgery or I cannot do surgery, and if I'm not gonna do surgery, physical therapy," or, you might have a few things that you're gonna recommend, but, so if they're told that they're not a surgical candidate, I think that is disappointing for a lot of people, but I'm glad that you explained that.
It's also disappointing for people who don't have hypermobility, but I feel like I need to extra explain to my patients with hypermobility because I know that they've been to multiple doctors and it can be frustrating to sometimes not have a solution. There are a lot of things like that in life, though. Arthritis that never goes away. And if you're a young person, maybe not a candidate for a total joint yet, or, that kind of thing. And so I sometimes feel like I have to break a lot of bad news to people. It's not like cancer, but like, it's like there's a lot of delivering of not the maybe what people want to hear sometimes.
I hear that. So, what about imaging? I feel like this is another thing that's really frustrating for a lot of people. They'll get their lab work done, they get imaging done, and the imaging is, quote, unremarkable, but we know that these are often dynamic problems. So, when is imaging helpful and when is it not helpful?
Well, I think it's helpful for diagnosing other sources of problems like cartilage damage. Again, like, is there any like anatomic harm done that's like grossly remarkable that we can make better with the surgery? In the shoulder, I think, an MRI with an arthrogram is very helpful for differentiating between just what I call capacious capsule, like just this extra like volume that the capsule can accommodate. It's like the bottom of the shoulder joint. I always describe it as like it should be a hammock, sort of the capsule like supporting the bone, the socket. And people with ligamentous laxity have a saggy hammock you wouldn't want to sit in. Your bottom would be on the ground. People with arthritis have a very stiff, uncomfortable hammock. It's like flat, like it has no give. You also wouldn't want to sit in that hammock, you know. But like an MRI with an arthrogram can see if you've got this capacious capsule, which I expect to see in people with ligamentous laxity. But you can also see again, like if someone had a traumatic event on top of their pre-existing ligament laxity, have they also injured or torn off their labrum? And, I just saw someone like that today who has been okay, had always had this sense that their shoulder could slip out of the joint, but then had this kind of slightly more traumatic event. And ever since then, now can't control it anymore. And, like, you can see on the MRI with an arthrogram a little bit of like kind of peeling away of the labrum at the back of the joint. So this person has done physical therapy at various times in their life and responded to it. But then had this new injury and done a course of physical therapy and not responded to it. And so we're gonna do a labral repair and a capsular application. And then I always have to caution people who have hypermobility that you're going to have a period of time where you're gonna have actually less you may have some less mobility. Your shoulder may feel a little tighter, which ironically, people who are used to having very mobile joints don't love the feeling of having a joint that is a little bit tighter because they're used to having it be so mobile. So there's just this interesting like contrast. um, I definitely think imaging can be helpful. In the hip, some people with hypermobility have other, not just ligamentous laxity or collagen issues, like sometimes there's structural issue related to the shape of the socket. You could have a shallow socket, like a dysplastic hip. So you instead of it being like a ball in a socket, it's just like not covered enough. And that can lead to micro instability. So I definitely think just because you have hypermobility doesn't mean you can't have other contributors that are making things worse. It could be like the shape of the socket, the orientation of the socket. Um, it could be, the shape of your patellofemoral joint. There are people who have generalized hypermobility, 9 out of 9 on the Baton scale, but in their patellofemoral joint, they have a misshapen groove. And, that can be addressed. So there can be multiple contributors in so many, in a lot of cases, there are um, contributors that can be changed. Your hypermobility in many cases is not going to be changed, but some of the aggravating factors, there are some that can be addressed. So the key is like, what can you find things that are addressable and that you can make better or not? And sometimes the answer is there's not something surgically addressable, and sometimes there are. So I I think imaging is very important, especially if you're not responding to the typical interventions that we would hope would make you better. So
We're going to take a quick break. And when we come back, I want to talk more about hips specifically and the difference between the whole IT band slipping or internal snapping hip versus true hip subluxation or dislocation. So we're going to take a quick break and we will be right back. I think we all have an outfit that we keep reaching for over and over again. And that's how I feel about my Cozy Earth jogger set. It is so comfortable, so soft. It's made from viscose from bamboo, and it's lightweight and breathable, and it just gets better and better over time. This is the outfit that I reach for if I'm hanging out at home or out running errands. It's what I want to wear over and over again. And I also really love their clogs. They're super comfortable. They have a lightweight cushioned footbed, and you can just slip them on to run errands or hanging out around the house as well. I also love that Cozy Earth offers a 100-night sleep trial and 10-year warranty. I don't know any other company that does that. I don't know about you, but this is a really incredible way that Cozy Earth stands behind their products. This spring, give yourself the kind of comfort that lives with you all day, not just the moment that you get home. Head to CozyEarth.com and use my code BENDY for an exclusive 20% off. And if you get a post-purchase survey, mention that you heard about Cozy Earth right here on the Bendy Bodies podcast. Comfort lives here. So we're back with Dr. Jocelyn Wittstein. So I'm really interested to talk more about hips in detail. So you mentioned about hip dysplasia, which is where the hip socket, is more shallow, which is something that you probably see quite commonly. And that can also be more common in dancers, right? Because that gives them the ability to
and
have
gymnasts,
a greater
yeah.
range of motion. Yeah, and gymnasts, right? And can be advantageous for them up until a point, until they start getting more arthritis and need hip replacement surgery, I would think. But can you talk a little bit about this whole, people get the sensation of like snapping in their hip, but a lot of the time it's either internal hip, it's either the psoas or the IT band, correct? Versus true subluxation and dislocation of the hip, which also can happen, right? But can you explain that to us?
Yeah. So the iliotibial band is at the outside of the hip. So you can have an external snapping hip. And it's that, band of fascia that it's called the IT band. So it goes from your iliac crest all the way down to your tibia. So it does, you're crossing like two joints. And women, of course, have like wider hips and this greater trochanter that can sort of snap, underneath the IT band. And that's almost like can be almost visible on the outside of the hip. And then dancers, for example, can be prone to like an internal snapping hip where the iliopsoas is just a little tight and rubbing over bony prominence. So, and that can be more with like sort of flexing and rotating the hip, um, as opposed to like hip subluxations. I I don't actually. I've never experienced that myself, but I think that people will feel like it. Well, they will describe this as like a clicking. They'll be like something more subtle. But you could also have that with a labral tear, and again, clicking, popping, all these things are really subjective and hard to sort out. You can have that if you have some people have femoroacetabular impingement. Those people don't really necessarily have true instability, but like the ball is over covered almost, and that can lead to labral tearing versus under coverage where you're just getting too much stress on a smaller part of the socket, and it's like less housed in the ball and socket joint. So again, this gets into where imaging can be very helpful, unless it's like really obvious external snapping, in MRI, depending on your institution, with or without contrast in the hip, can be like very helpful to sort of sort all that out. And X-rays are also really important for like studying the shape of the hip as well, of the socket and the neck. So um, I think yeah, like just sort of kind of blanket like everything is hypermobility in a person, or you have this global problem throughout your body should not be the answer, especially if you have certain joint symptoms. Like imaging can be very valuable.
Yeah, hictum's dictum, right? That you can have multiple things going wrong at the same time. Yeah. So what about um, indicators for surgical success? Are there certain things that you see that you think this means that the person is more or less likely? Like I believe that when I've looked this up, if a person has chronic pain, well, of course, everyone going into a knee replacement, for example, is going to have chronic pain, but there were certain indicators like anxiety, depression, trauma, like those things actually increased your risk of having chronic pain after knee replacement surgery. Are there certain indicators that you have seen?
Yeah, I mean, I think in general, we kind of expect things to provide a certain amount of improvement, and you're like starting from one place and ending in another. And there can be similar amounts of improvement, but maybe not as much. We do know that a lot about anxiety and depression, um, with many types of procedures like hip labral surgeries, rotator cuff repairs, things like that. Your starting point in terms of like, these scores that we assess for your overall shoulder well-being or your general shoulder well-being, or, physical function, mental health things. There's a place where people start, and there seems to be, people with these comorbidities, they see the same amount of improvement, but they kind of don't rate themselves as high at the end as people who don't have some of those comorbidities. Haven't seen a study specifically, I think looking at that necessarily with hypermobility, but um I do think that, yeah, there's sort of like a place where you start and a place where you end. And, um, one of the things that is associated with like knee replacements, for instance, is like your preoperative range of motion can affect your postoperative range of motion. I don't think that's so much likely, to be an indicator in someone with hypermobility. We talked about, again, people who have excessive knee extension can have like a higher failure rate with ACL reconstruction surgery. And so we can take some extra measures to try to prevent that. I think when I see someone with patellar instability who has generalized ligamentous laxity, I'm using a donor tendon, not their own tendon, to do the ligament reconstruction, just because there's really not much difference in the outcome of using something from your own body versus a donor tendon with that type of operation. But I also kind of think, well, maybe I'll use some other collagen. uh, so I think there's lots of things to consider there, but I do. This is a gestalt, and I don't have a study to back this up. I do see. I feel like a little bit more higher rates of anxiety in younger women with hypermobility than people without. And this is something I've never written about this or read a study of it, but I see a large association in adolescent girls with shoulder hypermobility, generalized ligamentous laxity, and cutting. I don't know if you've ever encountered that, but people cutting. And I've always wondered about that. And I don't know if it's just who comes to the orthopedic clinic, like people who have enough shoulder instability in the setting of hypermobility that they're like seeking advice from a surgeon. But I've wondered about it so much that I've thought about doing a study on it, but I don't know how to study it because I don't know what the baseline would be. But I don't know. Did that resonate with you? I don't know why I would see that.
Yeah, that's super interesting. So I literally just recorded an episode last week with Dr. Jessica Eccles. It's the third time I've interviewed her, and she's an expert on joint hypermobility, connective tissue disorders, and neurodivergence. And we know that there's a huge overlap with anxiety, tremendous overlap with autism, ADHD. And so I'm thinking with the cutting, yes, if there's more anxiety and trauma, and I'm not an expert by any means on the self-harm aspect of that, but we definitely were planning on talking about that in the next part because I only got through like a third of the questions that I wanted to ask her.
Maybe you can ask her. It's just something
I
I've
will.
observed. I specifically in hypermobility patients with chronic shoulder instability that they're not doing well with. I mean, certainly there's a large number of patients that don't have that. But on the flip side, like so often when I see an adolescent female who I see like cutting in, it's someone who's there to see me for that problem. And I don't know if there's a relationship or not, but I've wondered it so many times over the years.
I know for an absolute fact because this has been studied extensively. People with hypermobility and connective tissue disorders have experienced a lot of medical trauma. So that may contribute as well. It's extremely frustrating. I mean, you have all these problems and you go to doctors and you're told that you're crazy or made to think that way anyway. There's also, I think, a really strong propensity to gaslight yourself. When I was having a lot of problems with my knee, I was having a lot of problems. I'd fallen off a mountain bike and my orthopedic surgeon who had just done my knee arthroscopy, and then he did the surgery on I think a Thursday or Friday, and I saw him. I was at work on Monday, and I was doing a heart case, so I was like standing on my feet all day, and I see him in the doctor's lounge, and I said something about that my knee was it was sore, of course, and he said I looked inside your knee. There's nothing wrong with your knee, and it was like in hindsight, it's like well I had had surgery just a few days earlier.
Yeah, and I would not want to. I would say take 2 weeks off to let the swelling go down and the portals to heal. But yeah,
Nope. So, but my point was gonna be that because he said that to me, like, I didn't say, "Oh, well, he must be wrong." I internalized that, and I was like, "Oh, yeah." And it wasn't until years later that I remembered, "Oh, I had a bone bruise in my femur, and, he can't see inside my ligaments." So, anyway. So, that's a good lead in, though, to my next question, which is, how do you recommend you know, people who can come see you, I'm sure they're like super excited that they can come see you. But for the people who can't, do you have any suggestions for how to find an orthopedic surgeon who might be more understanding and or more amenable to altering their surgical technique because you have joint hypermobility or a connective tissue disorder like EDS?
well, I think that physical therapists have a good sense of that. A lot of times, physical therapists have certain patient population they've figured out, like who they could refer their patients to. I think that can be a good source. Probably have a good chance if you're seeing an orthopedic surgeon that was like a former gymnast or dancer, because, because they
That's a good
probably
idea. Yeah.
have some of that themselves. That's a really narrow search, but I mean, I think, um, well, I mean, I do think women are more likely to experience hypermobility, and so um, I'm not making a blanket statement about male or female orthopedic surgeons, but if you're just looking for like maybe commonality of experience, that might be more common and a more common lived experience in a female orthopedic surgeon. I don't know, but um, and there are many wonderful male orthopedic surgeons. I'm not making a comment about all orthopedic surgeons by sex or gender, but I'm just thinking about like how you might like find somebody that you feel like is gonna hear all the aspects of that. But yeah, it could be trial and error. And the other thing about orthopedic surgeons is like people are quite subspecialized. So I do think, if you're not gonna, it's gonna be, and this is frustrating for people, you're not gonna go to an orthopedic surgeon really anymore these days, and they're gonna take care of your whole body. Like that's not the way. That doesn't work that way anymore. So like a lot of sports medicine doctors are shoulder and knee, or there's someone who does a lot of elbow and hand or hip. I mean, hip arthroscopy and hip preservation is practically its own specialty anymore. You're going to have foot and ankle specialists. You're going to have arthroplasty specialists. So I think the other frustrating thing for people is you may end up seeing a lot of doctors if you have like a lot of focal complaints, and you probably do want to see someone that's kind of really specialized in that area. Um, but again, recognizing that a lot of these things are non-surgical, um, probably oftentimes maybe starting with a PT, bumping up to a surgical specialist, when needed. I could see again the medical trauma. You could end up going to a lot of doctor's appointments if you started every single thing with the in a doctor's office. Um, but yeah, I guess those are some general thoughts I have on that. There's not like a yellow pages of orthopedic surgeons that
Yeah, if you had I didn't know if you had thoughts about, like, what would be maybe red flags that, if somebody is talking to an orthopedic surgeon and they answer a question in a certain way that, like, that's what I guess where I was kind of also headed, although I appreciate that, yeah.
Yeah, well, I think if you're talking about orthopedic surgeon about concern for hypermobility, contributing to your condition, like, someone that doesn't, I think, one of the things that's important to do on during that visit or in that exam would be to do a Baton score, assess for someone like that, and then, one of the things I think is a little funny about the Baton score, it doesn't include anything with the shoulder, or the patellofemoral joint. So like there's certain things I'll check anyway. Like if I'm, you of course do the small fingers, the thumb to the wrist, the, elbow extension and the
Oh, look at that elbow, by the
yeah,
way.
I get some points, yeah.
Wait, let me get my goniometer out a
Yeah,
second.
yeah. The
That's a
knee
hyperextended
hyperextension
elbow.
and palms to floor. But I'll kind of just do a quick like patellar translation, a little sulcus sign in the shoulders. Cause again, some people don't have like that global finding. But yeah, like is there an appropriate assessment done? And then um and are your concerns like heard beyond like if you're just sharing like I have this. Um so on the flip side of things, I sometimes have patients who've been told they have hypermobility and their generalized hypermobility is the source of their problems, but then I'm seeing them and they're very not hypermobile. Like there are some people where their Baton score is like 0 out of 9 or maybe 2, and there isn't excessive patellar translation or there aren't sulcus signs. And I think um, I also don't want people to carry this some sort of definition or burden in their mind necessarily. I'm not trying to contradict someone, but sometimes someone will be told by someone at some point you have something, pathologic and maybe they don't. So sometimes we're like also like I'm doing a Baton score and listening to them and checking their patellar mobility and like kind of seeing how much sulcus sign or whatever they have in their shoulder and to get a sense of like there's so many times that someone comes to me with a complaint or a not a complaint because that doesn't sound like the well we call it a chief complaint like a concern and sometimes we need to like reorient a little bit because maybe that's not actually the problem. And I don't mean to say that to, like to dismiss anyone's concerns, but we have to like really, really assess that. So if someone's just not even assessing that, like that's not good. And that's a hard conversation too. Again, I think like there's a lot of fear of hypermobility. And then if someone tells you you have that and kind of but by exam and history, maybe you don't, like maybe you have something else going on, then we need to dig into that more. Um, but yeah, so I think, like, when you bring it up, is it assessed? If it's not even assessed, well, that's concerning, like, how would the person even know how if you have any signs of hypermobility, you know? So, I guess that's one thing I would consider. I mean, sometimes I see someone will say, "Oh, like, no one's even checked on me before," or whatever.
And I do wanna point out, a couple things before my next question. So, the sulcus sign is where you pull on the arm and you look for, like, an indentation because that's the shoulder instability, right? And I did also wanna point out that one of the types of hypermobility is historical joint hypermobility. So, I love the 5-point questionnaire for that. I ask all of my patients the 5-point questionnaire, which I think is really, really, really helpful, and I can link that to the show notes rather than kind of going through it because I have some other questions I wanna ask, and we're getting near the end, so
But you're right, there are people who had a long history of, Like they'll be like, my shoulders used to dislocate or this used to happen and now it doesn't. But now they have like again, sometimes an early arthritic joint.
Yeah. What about regenerative medicine? I've been dying to ask you about this.
Yeah, I think that there is reasonable evidence for um, reduction in inflammatory markers and symptoms of joint pain in people with mild arthritis. Most of the studies are done on the knee, for example, for platelet rich plasma that has reduced white blood cells, so like low white cell autologous conditioned plasma. Um, there really isn't evidence that stem cell therapy is superior to that. And again, this is looking at specifically like joint symptoms and joint pain related to early arthritis. Um, we ran one of my sports medicine primary care colleagues was one of the PIs on one of the largest trials. Looking at this and like stem cell therapy is just um it is much more invasive, more expensive, more time consuming, and doesn't really seem to do more than the low white cell autologous conditioned plasma in terms of dealing with like symptoms of mild to moderate arthritis. I don't personally use prolotherapy in anything in my practice. Doesn't totally make sense to me, but I know that sometimes people will use it for tendinopathies and things like that. There's mixed data on tendinopathies for PRP. For example, like lateral epicondylitis, some studies show it's effective, some studies not. If you sum them all together, it comes out to nothing. But there are certain things I think aren't harmful. And when the alternative is a surgery that doesn't necessarily always work well, I'm okay with trying that. Like I don't mind doing PRP for lateral epicondylitis, for example, or chronic patellar tendonitis when I don't think it's harmful if it's like within the means of a person. These things aren't covered by insurance. I'm not like trying to oversell them to anyone, but sometimes there's something we use as an alternative to try to avoid surgery.
Great, that's helpful. And what about physical therapy when it fails? Do you have thoughts as to when I say when it fails, when somebody you gave a great example earlier of somebody with a shoulder injury, but do you have any thoughts about what causes physical therapy to be unsuccessful, most commonly and or what people can do to help the physical therapy be more successful for them?
Oh gosh, I think that would very much depend on an individual situation. Again, it could be like the underlying bony architecture, the severity of a person's collagen disorder. Um, it could be the maybe you haven't found the right physical therapist for you or someone who's figuring you out. But yeah, I don't think there's like a global cause for like that I could quote for you as like cause of failure of physical therapy.
And I heard you, and the reason why I was introduced to you, well, I think I probably saw you on social media before I heard you interviewed on, I think it was Unpaused, Dr. Mary Claire Haver's podcast. And you, of course, were talking a lot about hormones, and I know that that's her wheelhouse. You're the orthopedic surgeon, but have you, yeah, have you made any observations in terms of joint stability, instability, joint pain when it comes to hormones?
Well, yeah, I mean, there's a lot of oh gosh, I mean, so much. There are estrogen receptors in our joints that can affect the inflammation in our joints, right? So, in the absence of estrogen, there can be then this like upregulation of the inflammatory processes in the joint, which can lead to cartilage breakdown. That's kind of part of why menopause is a time when we see this shift or increase in joint pain and earlier arthritis in women than men. But also tendons, have estrogen receptors. There's like definitely an uptick in tendinitis and tendinopathies, things like plantar fasciitis, gluteus medius tendinopathy, in midlife as well. Um, Interestingly, there are some studies to suggest that obviously estrogen has some effects on collagen synthesis. And we think about estrogen as affecting ligaments in terms of keeping them like where they may be able to tolerate like more stretchiness, right? Like they're like more lax, but the collagen may also be more organized. And so we're studying that now. In ACLs, and people with normal ACLs, we're looking at hormone levels and kind of stressing the knees and using these models we make to see, like, with different hormone levels, estrogen, progesterone, testosterone, relaxin, like, what are the strains that we're seeing on the ACL. Um, but we also think, that estrogen levels and um, cyclical changes in estrogen levels may relate to why women are more prone to ACL tears. And so it's not quite clear yet, actually, if there's a particular phase in which women are more likely to injure their ACLs. And like, I don't even think if we know, like, are you more likely to tear your ACL when it can tolerate being more stretched, or are you more likely to tear your ACL when maybe there's like disorganization of collagen fibers? And in some of our preliminary data, we did see that the signal intensity ACL like suggested better organization of the collagen fibers when estrogen levels were higher. But we're still looking into this. This is very early. So there are certainly hormonal effects on tendons, joint inflammation, ligamentous laxity, and that may affect women in the premenopausal state with cyclical changes, and then obviously in midlife with more ongoing changes, and then there's also the influences of hormone therapy, and so there's a lot to continue to study here.
Yeah, like you said, you have birth control, earlier in life that a lot of people are using, and then hormone replacement therapy later that a lot of people are using on the other end of that.
But I do think also, like, if you're a hypermobile person and then you go through menopause, I do think you could like stiffen a little bit. And I don't know and then how does like the menopause transition with hormone therapy, how does that affect hypermobility? Like I'm not sure. But something to think about.
Well, it is interesting because I see with a lot of people once they go through menopause, the perimenopause can be really rough for a lot of people because obviously hormones are really all over the place. But once they go through the menopause transition, then the more steady state, whether they're on HRT or not, can be a lot better, especially from the standpoint of their mast cells, because mast cells have hormone receptors on their surface as well. So their mast cell symptoms can get better.
Yeah. It's a rough transition for everyone, I think.
Yeah, yeah,
Yeah.
definitely,
Yeah.
definitely. And what about testosterone?
Oh, well, there's some information that in women, actually some pretty well done studies showing an inverse relationship between testosterone levels. So lower testosterone being more associated with knee pain and actually development of knee arthritis. And so there may be some joint pain ameliorating effect of testosterone. Some data suggest that in knees, but not in hands. And so again, I think we're learning more about this, but there are a couple of studies supporting an inverse relationship between testosterone levels and knee pain and knee arthritis in women specifically.
Yeah, I prescribe testosterone to, you know, fair number of people, and I personally use it, topical testosterone, and I find it to be very helpful. Well, this has been such a great conversation, and as you may know, I like to end every episode with a hypermobility hack. Do you have a hack for us?
Oh gosh, hypermobility hack. Well, I think we talked about some of them, which is you want to avoid. This is very obvious, but I'm like saying this for like younger people with hypermobility. Like avoid demonstrating repeatedly that your joint can go out of place or how it goes out of place. I think that a lot of people do this when they're younger. Not as a party trick, just like, hey, look what this does. Like you want to actually avoid that if you can. And then, in line with that, like avoid like yes, you have extremes of motion. But if you don't need them for what you're doing, like don't do like exercises or movements like in the greatest extreme. So like if you're strength training, like you don't have to use your full arc of motion. You can, limit the arc of motion to not be in the extreme of range of motion that's going to elicit some of that instability. So, um, I think, yeah, just like trying to, they seem like really common sense things, but sometimes I say them to people and they're like, oh, yeah, like you don't have to use, you're not going to like pathologically lose your extreme ranges of motion, but you don't have to like always use the whole arc of motion. Unless you're, a ballerina on point and needing to do it, in that moment. But so I think avoid the like unless you needed to, like in a doctor's office or whatever, like avoid just sort of like demonstrating it, even though it like will do it. It's just you want to avoid, if possible, these repetitive cycles of popping your joints out of place. Not that, and some people can't control that, but if you can control it, avoid it. Each of those is a little bit inflammatory to the shoulder, I think, over time, or the knee or hip or whatever. Yeah.
I referred to that on a social media post as the fun phase of hypermobility.
Yeah, I know. To the teenagers, I'm like, don't do that. Like, stop showing your friends that. It's like, later on, you're gonna wish you weren't doing that. Yeah. So it
Yeah, because it doesn't hurt then, right?
doesn't hurt
So
then.
that's
Right, exactly. Yeah.
that's the problem, but it's like me with my skin cancer now. I'm so aggressive with the sun and my protection, but it's a little late, you
Yeah.
know,
Now you need
when
the
I
vitamin
when
D
I
supplement because you're not out in the sun. So,
yeah, yeah. I should have been doing that a long years before I actually developed, so many skin cancers. I tell people to videotape themselves or I videotape them when I see them for their appointments, and that way they have some evidence of that they could do those tricks so that later on in life, if they're going to an appointment and, somebody asks them to yeah.
oh yeah, that's a good idea. So they don't have to like repeat it. Hmm.
Yeah. And especially I often say, if you're doing like the EDS gangsta sign, put it up by your face so we can see that it's you. you know? Although now with AI, yeah, it'll make people can probably uh, alter photos if they want. But so yeah, I often tell people to do that because that way they don't have to keep demonstrating over and over again. And if you're at a teaching institution, which obviously you are, sometimes they'll bring in the medical students and the residents
Yeah, and
and
it's like
and
10
want you
people
to
are doing that. Yeah.
right. I've heard that from people. Yeah, they had me do it, and then they had me do it again, and
Yeah, I don't make people repeat that if or my resident says they're 9 out of 9, I trust them. I don't make them repeat that.
yeah,
So,
that's good. That's good. Okay, great, great. Well, I really appreciate you coming on the Bendy Bodies podcast today, and it was really great chatting with you. Can you let us know where we can learn more about your work, and if you have any special projects or anything coming up?
yeah, well, I'm an orthopedic surgeon at Duke. I'm kind of a Luddite. I don't have my own special fancy website, but you can find my professional website at Duke. um, I'm on Instagram. It's Jocelyn_Wittstein_MD, where I mostly share like bone and joint health literacy. Oh, I actually have a reel on how to do a bite and score on yourself on there. I have a book that I co-authored, which is the Complete Bone and Joint Health Plan, which is more related to arthritis and osteoporosis education. So, some of the aspects of like reducing joint inflammation, anti-inflammatory diet, some things like that might be relevant to people who are experiencing joint inflammation. Um, but yeah, and I have some ongoing research, as I mentioned, looking at the effects of hormones on ACL laxity, um, effects of hormones on joint health, frozen shoulder. And then, my other work that I do is related a lot to post traumatic arthritis. So, arthritis that develops in young people in response to injuries like ACL tears and things like that. Probably not relevant to your viewers, but yeah.
Well, I do wanna ask, I know I promised that we were gonna wrap up, but I'm so glad you mentioned frozen shoulder adhesive capsulitis because, I think this is something that's so confusing. I've had it now multiple times in my left shoulder, a couple times in my right shoulder, one time after a fall, but then one time I just woke up and it was frozen. And I have hypermobility, so this was like, "What?" Um, do you think that people with joint hypermobility or connective tissue disorders, do you see that a difference in terms of how frequently they get, adhesive capsulitis or frozen shoulder?
This is my take on adhesive capsulitis and people with hypermobility. You can definitely get it. It may not be as obvious to you or the provider that you actually have lost range of motion because it's really important to compare it to your other shoulder. So someone who's very hypermobile, their normal mobility may be like 120 degrees of external rotation, like I have. Whereas for many people, just simply 90 degrees of external rotation is like for many people, this is a normal arc. If you have 120 something, but now you have like 80 on this side as compared to like 120 on this side, you have like a 40-degree difference in range of motion. That may be how you're presenting with like an early frozen shoulder or even like kind of getting into that frozen phase. It's normal for some people, but for someone as compared to your other shoulder hypermobile, like you may actually have lost quite a bit of motion. Not that you don't have a functional arc, but it's just a sign of that might be what's going on. So you have to really compare a range of motion side to side if you're trying to detect adhesive capsulitis and someone who has a history of hypermobility. And certainly it's kind of a thing that happens to perimenopausal and menopausal women. And as we mentioned, one of the things that estrogen withdrawal can do is it can lead to inflammation in joints. And estrogen actually can inhibit cells called fibroblasts that can sort of make the capsular lining of the joint like more dense and less stretchy or flexible. And so you can kind of tip into this process of the joint getting inflamed and then getting the lining getting fibrotic and getting stiffer um, in this transition as your estrogen levels are shifting. And so that could happen to someone with hypermobility for sure.
And it can be very painful. And
Yeah.
in the beginning, right? In the beginning phase can be very, very
And very
painful. And
inflamed
then
and painful. Without any trauma, you could just wake up like that.
that's what happened to me. One of those times. Yeah. 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 One of those times I just woke up like that and was like, but then the pain got better, but it was still frozen. So,
Yeah.
but at least
And that
the
was
pain
the
was gone.
stiffest your shoulders ever been, probably.
Yep. Yep. Most definitely. Most definitely. Okay. Well, thank you again. I know that you are very, very busy. So I'm really grateful to you for taking the time to share your expertise with me today.
Yeah, thank you for inviting me.
Thank you so much for listening to this week's episode of the Bendy Bodies podcast. If you'd like to go deeper, I share additional education, clinical insights, and resources in my newsletter, The Bendy Bulletin, which you can find on Substack at hypermobilitymd.substack.com. You can also help us spread the word about connective tissue disorders by leaving a review, sharing this episode, or sending it to someone who needs it. These small actions truly make a difference in raising awareness about conditions that are still widely misunderstood. And don't forget, full video episodes are available every week on YouTube at Bendy Bodies Podcast. As many of you know, I offer one-on-one coaching and mentorship for both individuals living with connective tissue disorders and people caring for them. You can learn more about these options on the services page at hypermobilitymd.com. You can find me, Dr. Linda Bluestein, on Instagram, Facebook, TikTok, X, and LinkedIn, all at HypermobilityMD. As part of our collaboration with the UVA Ehlers-Danlos Syndrome Center, we also want to share some of their helpful resources. For questions or appointment inquiries, you can contact the UVA EDS Center at ruvaedscenter@uvahealth.org. Again, that's the letter R as in Robert, UVA EDS Center at uvahealth.org. You can find answers to common questions at uvahealth.com/support/EDS/FAQ. Our incredible production team is Human Content. You can find them on TikTok and Instagram at Human Content Pods. As you know, we love bringing on guests with unique perspectives to share. However, these unscripted discussions do not necessarily reflect the views or opinions held by me or the Bendy Bodies team. Although we may share healthcare perspectives on the podcast, no statements made on Bendy Bodies should be considered medical advice. Please always consult a qualified healthcare provider regarding your own care. For more information about the Bendy Bodies program disclaimer and ethics policy, submission verification and licensing terms, HIPAA release terms, or to get in touch with us, please visit bendybodiespodcast.com. Bendy Bodies Podcast is a Human Content production. Thank you for being a part of our community, and we'll catch you next time on the Bendy Bodies Podcast. Thank you so much for watching. If you enjoyed this video, give it a thumbs up and leave a comment below. I love getting your feedback. Make sure to hit that subscribe button and ring the bell so you will never miss an update. We've got plenty more exciting content coming your way. And if you're looking for more episodes, just click on one of the videos on the screen right now. Thanks again for tuning in, and I'll see you in the next episode.